Thank you, Lisa. And I also want to welcome everyone on a nice Wednesday night. Obviously, for many, if not all of us, a long day in the office, a little dinner, and perhaps a little favorite beverage as we just, have a little time together tonight. So tonight we're going to talk about creating beautiful composites and temporaries worth your signature. One of the things I want to share with everyone is this, I became somewhat convicted of my work when, we want to have our name on everything we do. We want to be proud of everything we do. There's no question we live in a time of aesthetics, and our manufacturers have provided materials and procedures that allow us to achieve, in most situations, beautiful aesthetics and also fillings and restorations that will last a long time. So let's get started. As Lisa had mentioned, and this is just a disclaimer, I am a member of Catapult Education. I've been with Catapult for many years. And we also, not only do we have speakers, but we also speakers and evaluators. And what we do is companies will ask us to evaluate products that they have in the dental market and give our opinions after we have used these products. You might, for instance, if we're evaluating a composite, it may be a situation where they ask us, how's the color come out? How's the shade come out? The hue, how about handling? How's the handling? And did you like the margin adaptation? So there's a whole area where we would do this evaluation. If after we evaluate it, it reaches a certain level of acceptance, then the product is given a vote of confidence, a Catapult vote of confidence. So that's what we do besides speak. Also, this disclaimer says that I do not own any of these products that we're going to talk about tonight. I do not own anything in Kettenbach. I wish I did, but I can honestly say that I don't. And so let's introduce our sponsor tonight, Kettenbach. Kettenbach is a dental company out of Germany, and it's a fantastic company. They have multiple products. One of the most recent products is the Proficil, which is a fluoride, and it's incredible fluoride. And as you can see here, many of their products we use every day in a clinical situation. So after this evening, take a look at all their products. So what we're going to do tonight is we're going to highlight their composite. It's Visalis Fill and Visalis Flow. When this product came out, and it did achieve the vote of confidence by Catapult, I was so impressed with this product. I mean, it is one of the easiest and most beautiful composites that I've ever used. And it's very adaptable to the margins, and it's just incredible to use. Their shade selection makes it easier to use in the anterior and the posterior. So it's a universal, and you're going to have some test questions afterwards for your CE. So it is, and I quote, a universal nano hybrid filling composite. It has a flowable and also a fill in their flex. And as you can see here, you can use it in many different classifications. You can use it as a core buildup, but it is very, very nice to handle. It really adapts well, and it just gives a beautiful, beautiful appearance after you're done. And so the mechanical properties, it's a higher filler content, and it has excellent flexural strength. So that's something to be considerate of, especially in the posterior when you're doing occlusal composites, is how strong is this material that we're working with, and how well does it adapt? Is it, does it work under good stress? Because as we know, many of our patients, they clench and grind their teeth today. And here's the flex shade. And when you see some of the restorations that I'm going to show you tonight, you'll see how well it adapts. It gives that chameleon, that's a hot term in composites nowadays, is it gives that chameleon effect. And what that really means is it just encompasses the shade of the tooth itself. So the other thing we're going to talk about tonight, there's actually a couple of things, is we're going to talk about Visalis Temp. I've used Visalis Temp for many years. I've used it for different situations, but this is an incredible temporary material. Very, very nice temporary material, and it's very reasonably priced also. I have to tell you that it's really very nice, but it's very strong. It's extremely strong. It's unbelievable how well it holds up, and it adapts well to the tooth. And I'm going to show you a quick procedure to take out all the hurdles. Like most of my single unit temporaries I have done in 5 minutes or less. And I'm going to show you how to do that. These are the shades that are available. And so we're going to highlight those two. And if time allows, we're going to go on to a couple of other things. But it's just easy handling, high aesthetics. The shade selection usually works in every situation. So this is your typical, many of us see this every day. Who knows how long these alloys have been in there? Usually the patient will tell you, I've had that for 30, 40, 50 years, who knows? But as you can see, it has a little creep around the margins, and it's pitted. And but you know, it's time for replacing it. It's leaking. So back in the days, I would replace it, and I would look at this and I go, you know, we all put beautiful, beautiful indirect restorations in. And I would look at this and go, why can't I achieve the same results with the direct composite as my indirect restorations that my talented lab technician gives me? And it got to be very frustrating. I mean, this is ugly. This is yuck. It's functional. It's adapted to the margins, but it's not what I want for my patients. It's not, I know it's in the posterior. We all know that. But I wanted to provide something just absolutely beautiful. Same situation here. Okay. I tried to, you know, at that time, tried to add a little grooves, but let's face it. It's adaptable, it's functional, but it's ugly. That's the truth. And those I did many years ago. So what was some of the keys for achieving beautiful composites? You know, I thought to myself, what is it that I need to do? Well, one of the things, first of all, is I just need to make sure I have enough time in my schedule. When I do these, take the time and make sure you charge the appropriate amount for that. But just take your time and do a good job. As you do more and more of these and the procedures I'm going to show you tonight, then what happens is your speed will get better. But there's some hurdles that I really had to look at. How can I achieve a beautiful, functional, adaptable results that I wanted to have in my own mouth? So one of the things that I do routinely is I take with an intraoral camera, or just with Shofu makes a dental camera. It's called an eye special. I take photos and I evaluate myself. I'm critical about the work that I place in someone's mouth, the restorations. I'm very critical of that. So with photography, I noticed that my work started getting better because I would look at it, I'd study it and say, here's what I need to do different. Also, the technique. And for years, I've actually taught the techniques that after, you know, I got better at this, the technique made a huge difference. And then the last thing is the materials. There's no question over the years, when I got out of dental school, we had 2 composites, and I'm going to date myself. We had adaptic and concise, and you had about 3 minutes. And at that time, we were just using them in class 3 restorations, and we would just etch the enamel. If you got etch on the dent, and you flunked because everyone thought it would kill the pulp. So you had to mix the base, the catalyst, put in a centric syringe, and inject it. But materials nowadays, what the manufacturers have provided for us, is there's no reason why we can't achieve beautiful results. Excuse me, I'm going to take a drink. So let's take a look. This is our first patient tonight. This is a patient that says, you know, replace the alloy, then replace the gold. Basically, I want white teeth. And also, you'll see that I also made that, it's a composite, a cuspid that I actually, it was malformed, but I made it look like a regular one. So both teeth were asymptomatic. So here we go. We removed the amalgam. And if you notice right away, over the marginal ridges, there's some real fine cracks. So I prepped the tooth, and lo and behold, what do we see? Oh, yeah. So the decision comes, what do we do with it? Should we remove it and make it a MO, or do we leave it? So a couple of questions that we need to answer. Do you prep into the crack marginal ridge? Okay. Do you then weaken the marginal ridge? Because when you add most of the time, if you don't have to prep the marginal ridge, the tooth is stronger. We know that. What is the opposing occlusion in regards to number 20? So that comes down to is what it really comes down to is everything comes down to occlusion in most cases. What is banging against this tooth? And is there a plunging cusp that needs to be adjusted on that marginal ridge? So what I did was I made the decision not to prep it, to leave it. And as I mentioned earlier, the composites today allow us to mimic nature. So decision has to be made. Every time we do a composite, we have to decide on what type of bonding we're going to do. Are we going to do total etch, selective etch, and selective etch, or self etch? So if you have ever done an exam and you look at a composite that's been in the mouth for a while, and you see a little ring around that composite, and it's usually brown and stained. And a lot of doctors think that just stain around the margin, the cable surface of the margin of the composite. But what that really is the doctor used a self-etch adhesive on enamel. We're not quite there yet. In other words, what I'm saying is that the self-etch adhesives that we have today, there's one company that is very close and may have the secret to it, but we're still waiting to see. But the self-etches that we use today cannot break down the inorganic matrix on that enamel. And the result of that over a short period of time is that brown ring around that. So in my hands, I use selective etch or total etch. And that's what I use every day in practice. So let's take a look. So here's selective etch. I'm going to place the etch around the enamel. I'm going to rinse and then just surgical suction, a little suction tip, and blot dry. Now, my next choice is what am I going to use for my bonding agent? I'm going to use a universal. And my two universal bonding agents is Beauty Bonds by Shofu and Zip Bond by SDI. Why do I use it? Because it bonds to everything. There isn't anything in dentistry I do that where it doesn't bond. The other thing, this is one area. I want to go back here. This is one area where doctors can achieve sensitivity. Please, doctors, make sure that your assistants don't, or the doctor does not over dry dentin. You desiccate it. That is one of the number one reasons today that we get sensitivity, if you get sensitivity. But quite honestly, I don't see sensitivity like I used to years ago because we have a better understanding of the chemistry. So what I do is once I have done my selective etch and I'm going to do a self-adhesive, such as Zip Bond or Beauty Bond, I scrub the living daylights. If I'm doing total etch, I even scrub it more. But just don't put your bond on there and just wipe it on. Scrub the living daylights out of that dent. Just scrub, 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 scrub. And then you let it set just for a few seconds. And you're going to, and here it is with Zip Bond going in. And a good 20 seconds. I always say scrub the bonding agent as long as you also etched. The next step is air drying. In my office in Chicago, I've practiced in Chicago 1 week and in Naples, Florida the other. We have a dedicated air. I cannot tell you, if you could get this in your office, how important this is. I know that with the 3-way syringes that you take, and I do it, you push the air button and you bang it, but there's still water in that, okay? So we have a dedicated air that is worth every amount of money that it took to put that in there. And so what we do is we start gently for 5 seconds, and then I increased it. Now, why do we, after we place the bonding agent, why do we blow air? You want to evaporate the medium, either acetone or ethanol, depending on your bond agent that your bonding agent is in. And then what I do is I will cure that. Here's one of my favorite lights. It's by SDI. It's Rad 2. And the reason why I like it so much is I will cure it and rotate it. Like when you're curing composites or bonding agent, rotate it around so it gets in different angles. So I will cure that bonding agent. And then, by the way, test your lights, doctors, because for many of you, you will find out they're not as strong as you think they are. And the thing I like about this is I'm no different than anyone out there. There gets composite. I know you put a sleeve on. Sometimes you don't have that sleeve on, you cure it, and it's on that curing light. The beauty of this is that that plastic is replaceable on this light. So this light soft start, in other words, the first 5 seconds, it ramps up its energy and it minimizes the polymerization stress and shrinkage factor as depending on the composite. But it ramps up. So you're going to cure that bonding agent. Again, test your light. And then I'm going to place a small layer of flowable. So what I use Visalis Flow, and it adapts very nicely to that floor of this composite. And I'll put it in there and just let it set for 5 seconds and let it level. And then I'll light cure it. After I light cure it, and this is what diagram, this is a diagram in the class 2 situation, but you can see how that flowable adapts very nicely in there. And then I'm going to layer it with the Visalis fill, and I'll make my shade selection, okay? And so a lot of patients say, well, it doesn't matter. It's in the back. I don't see it, but it matters to me a lot, really does. So I'll do my shade selection, the flex shade here. It gives you exactly that shade. And you'll see that you can be a shade off sometimes, and it still will have a beautiful chameleon effect. But I'll show you an example where I probably should have gone a little lighter on one. So this is a must. So I don't know how many of you have ever used a heat composite. You heat your composite, you warm your composite. But I will tell you, it's a difference of night and day. If you have ever seen someone use heated composite, the fill almost just flows, and you can adapt it to the prep walls. And it just goes up to that cable surface so nicely. And there it is. We're going to polish. And my polishing technique is I'll use the One Gloss by Shofu, and then I'll use the Groovy Diamond by Clinician's Choice that has silicate impregnated. And I like these to come out. Now, this is the final results. Did the crown, and I also redid the cuspid there. So I redid the whole thing, and you can see that that worked good. So let's take a look at this one. Okay. This patient's chief complaint, can you stop the food getting trapped between my teeth? Well, what decision do we have? One, orthodontics or restore? Well, the decision actually came pretty easy, but that's because there was decay already present. So it's a good size interproximal space. And so we decided to restore it. Okay. And so there it is. So the first thing I did was we prepped it. We did our selective etch. There's my matrix band. And that's the other key to get nice contacts. And so what you want to do is you want to make sure that you knew this is a Garrison system. There's a lot of good system. Ultradent has an excellent system. But you want to make sure that you put that matrix band adapts well, and you also seal off that cervical area with a wedge. You want to rinse and dry. Okay, so we selective etch. I'll place my zip bond. We'll dry it with the air, evaporate the medium, and then cure it. There's our syringe. And there's our Visalis flow right there. Now I'm going to layer that composite. And this is important that, again, I'm going to use my heated composite and I'm going to adapt it very nicely to the walls. Okay. Now, I'm going to share something with you that is the most forgotten part and procedure of composites, and that's the bevel on the cable service margin. It is by far the most forgotten part. And so why do we do that? The reason we do that is so that the composite can have a nice smooth margin and adapt to that. And it also, when we etch that, it just strengthens that instead of like a butt shoulder. So for the adaptation of the composite fill, it just makes a beautiful situation. Again, I'm going to heat it. Now, this is the difference between heated composite and regular composite without heating. I don't know about many of you, but sometimes I'll get up in the morning if it's the day I'm not going to the office, and I'll have a little breakfast with my wife, and lo and behold, someone didn't fill the butter dish. So I have to go to the refrigerator, get that out, and then I will go to spread it. Now, the difference between spreading, and for many of you, you know what I'm talking about, cold butter versus warm butter is night and day. So, you know, it breaks down. It's just a little, that's the same. I use this as an example to show you the difference of warm heated composite versus unheated. The adaptation, the spread of it, it's so much nicer. The last thing I'll do in all my interproximal composites is I'll use a number 12 Bard Parker scalpel. And what I use this for is on the buccal and lingual to trim and make sure that the composite is nice and adapted to that wall, interproximal wall, and also get rid of any possible overhangs in the cervical area. It's just an easy instrument to have right there. And it finishes that so nice. And I'll use the Shofu Super Snap disc to just polish that. So if we look, and then our polishers, the one gloss and also the Groovy Diamond. If you look here, we went from this to that. Now that's a composite that I'm proud to put my name on. A lot of times I would love to have more anatomy. Sometimes the opposing occlusion doesn't allow that. This was done with Visalis Fill A2. And so you can see here how nice that chameleon effect comes about. Nice composite. Now, if you notice, the tooth itself is slightly rotated. So that turned out very nice. And it also, the patient was happy. They no longer got food stuck there. So this is a patient that you can see with plenty of interproximal decay. So in our office in Chicago, we run all our 2D bite wing x-rays through an AI, through Pearl. And it's a great, I don't know how many of you have AI, but I would encourage you to take a look at it. I do an all-day lecture on it and show how to implement that into your restorative treatment. And so what we see here is, as you can see, plenty of interproximal decay. You put it into AI and it points it out. Obviously, the pink is decay. And it can also, for educational purposes, we could show the patient, and that's what I do in treatment planning and to get treatment acceptance and educate the patient. It shows you how deep it is. Then if you hover over that, it will tell you what percent is in dentin and what percent is in enamel. Now, the question is, how accurate is this AI for when we get ready to prep? Well, let's take a look. Does the AI equal the clinical findings? And I can tell you AI can be wrong, but here's that exact mesio on that number 3. I would say it's pretty accurate. I didn't measure the percentage, but there's definitely decay there that you can see. And on the distal. So I prepped that, conservative preps. There. And also prep number 2, a heated composite. And there's the results with the VESALIS fill. Now, if you look at that, I'm very proud of that. It's hard to see in that where the composite is as far as shade adaptation and that flex shade that VESALIS has. There's number 2 and number 3. Very nice. Very proud of that. Happy. So let's take a look at anteriors. We see these every day. And here you can see there's some recurrent decay. And so we're going to prep it. There it is. You can see the decalcification in the decay. Yep. There's my bevel. Especially on the linguals of anteriors, I can't emphasize enough how important it is, because it just makes it so much easier to enamelplasty, to blend that right in with the enamel. Heated composite, especially in the anterior, if you're using a mylar matrix, that is so nice to have there. And there's the results. I try to do my best to make it disappear. So let's look at another class 2 here. So obviously, there's the prep. There's my matrix. Yes, I did. I forgot to bevel it. So I took a few minutes and took a little football-shaped diamond and just go around that cable surface. And there's the results. Remember, I shared with you earlier about perhaps there's times where I wish I had just a little lighter shade from the flex shade. This is one of those situations that, yeah, I could have gone a little lighter. But, we got light on that too. But if you also look at the buccal and lingual where I use that number 12 scalpel, you can see how the margin of the axial wall adapts so nicely after I use that number 12 and go in there and just smooth that out, and then just take a finishing disc in there and just blend it right in. It just works so nice. And start thinking about nice anatomy, nice anatomical restorations. So there's that number 12 there. So sometimes you get into a situation where it's what I call a combination. It's a combination of composites and maybe an inlay. Every time I do a restoration, I always think about, is there any way I can conserve it? Can I save tooth structure that is good supportive tooth structure? If it's not supportive and it's the supporting cusp, then we want to take a look at what is our selection of restoration here. So in this situation, I wanted to do an inlay on the patient and a couple of composite restorations, and that's exactly what we did here. So you can see, did the inlay first and then prep the 2 composites. So that turned out very nicely, shade and grooves and everything. Here's a situation where we have open contacts on both sides. Patient was just tired. Now, could we do ortho? Yeah, but if you notice also, there's actually stain there. I think, yeah, I just lost power for a minute. Are we still? Yeah, we lost stain there. There's some stain and actually some decay. So the results is this. So that adapted well. So let's switch gears for a minute and let's talk about something that many of us see throughout the day, throughout the weeks, and that is getting a tooth back from the endodontist. And this is generally the picture that you get. You get the access opening with the temporary in it. I always tease my endodontists that I refer to and say, I want you to remove one of those cotton pellets one of these days after you guys place them, because I swear they take forever for me to get them out of there. And you want to make sure, obviously, you don't go through the furcation area. But, you just caution, and sometimes it just on and on, get out of there. Or the sponges come out much easier. So what we want to do is I want to show you a really cool way, an easy way to do a core. So obviously the endo tip. And the first thing I do is when I get this, I'm going to take an impression of this because I'm going to do a crown on the tooth, and then I'm going to make a very nice temporary. So the material that I use is by Catapult called Silginate. And what it is it's an alginate substitute. I did not care for alginate. I hated alginate. In fact, I thought I was going to flunk out of dental school. I could never mix it right. But the thing that bothered me about alginate was that you had to pour it right away. You shake up this can, you get it fluffy, you open it. I always wanted some genie to come out. And then you 3 scoops, level it off, put it in a rubber bowl. Then you had to make sure you had exact amount of water, right temperature, mix it. Take the impression. 1, the impression had to be poured right away. 2 is that you had excess left over, plugged up the sink. It was a mess. So when the dental manufacturers came out with alginate substitutes, it was fantastic. I was in heaven. So the other thing nice about Silginate is it actually can be scanned. You can digitally scan this. So when I get ready to do a posterior or even anterior restorations, I take a Silginate impression first. And in the posterior, I just find a really inexpensive triple tray. And I think they're about $1/4. And I take an impression. I use Silginate. Have the patient bite down, make sure they're biting down. And this is what it looks like. Now you can see here on the upper and lower border of that, I trimmed it with a scissors. I'm going to make my temporary from that once I take the impression. So let's look at a core buildup. So this is my beginning prep. And as many of you can see the gutta percha in there. So Visalis has the sim core, and it also has Visalis core. And this is the core material. And so in a few minutes, I'm going to show you the sim core. So what happens is that it comes with a tooth primer. It's actually a self-etching primer. So what you're going to do is you're going to do your initial prep. You're going to take the Visalis tooth primer, and you're just going to rub it in there for about 20 seconds. And then you're going to air dry. There's your tooth primer. Comes with the kit. And then you're going to fill it with the core material, Visalis core. And then you're going to cure it. Obviously, I always cure right amount of layers, 2 millimeters through. But it's also self-curing itself. That's the beauty of using this inside the pulp area, is that if your light misses it, this is a self-care. It's a dual cure material. You're going to finalize your prep. You must finalize your prep, obviously. Now, when I take a single posterior, I like to use a tray, and this is my go-to tray called Tri-Bite. And the reason for that is, I don't know about if you have experiences, the borders on those skinnier trays, like the kind I use for the temporary, it interferes sometimes when the patient bites down. And again, every time you use a triple tray. Now, my lab technician, we call this a power bite because truly, if it's done right, will give you a most accurate bite the patient can have. Now, I do not use this for more than 2, anytime more than 2 restorations, impressions. I'll use a full arch tray and take a bite. But this gives you a true bite because the patient's biting down. So when you place this tray, make sure on the opposing arch you check that their teeth are coming together. And I also try the tray in before we do it. So I'm going to use Catapult's Panasil. Now, the beauty of Panasil is that they say you can take it with a moist prep. I still dry mine. But this gives you the array of what they have available. You have extra light, which if you notice has a 4-minute set at the bottom. You have extra light fast. This is a beautiful material that adapts to that prep. And then they have, the original was a contact. They since have changed it to the light. extra light, fast. And then the tray material, what I call the tray material, is called regular and regular fast. So the only difference is the fast is 1 minute sooner. So if I'm doing a single prep, I'll use that. If I'm doing more than one prep, I like a little more time. And this is the results. So I used an extra light fast and a regular fast on this. And there I have a nice shoulder. My lab technician can give me a beautiful restoration. So for many offices and for many doctors and assistants, and many times the assistants do make the temporary, it is a hurdle. It just takes so much time. Again, I want to show you how to do this, a single restoration in 5 minutes or less. Here's our VESALIS temp. So remember the impression, it did achieve the vote of confidence, comes in multiple shades. It's easy to use, it's strong, it's reliable. So what I do is take my original temporary impression, and I will try it in and make sure the patient can bite back into that. If not, I'll trim it, make sure it seats right. I'll fill it, place it back in the mouth, wait 1 minute and 40 seconds to 1 minute and 50 seconds, and I time it, and that's the temporary. This temporary I did not touch. No trimming, did not touch. That's the way it came out. And you can see on the lingual, did not touch that temporary. It's as easy as pie. Now, many times I do not cement my temporaries, I'm sorry. I do not cement my temporaries, okay? So what I'll do is they may lock on and I'll cut them off. That's okay. They didn't come off. Okay, there you can see it up close. All right, so I'll smooth where the endo temp was, check the occlusion and adjust. Now, if your prep is not as retentive as you would like it, sometimes you just can't achieve that. Then if you do have to cement, I want to share a cement, because one of the things that I don't like is getting a call on a Saturday at 5 o'clock. I've watched college football, or I'm having a glass of my favorite beverage, and a patient calls, says my temporary's off. So if you use this temporary material called Neotemp by Waterpik, you will cut your temporaries off. Again, most cases, I always cut my temporaries off because I lock them on and I don't, the patient doesn't floss. I get it. They keep it clean. I tell them to avoid chewing on it. But for a couple of weeks or a week and a half, I get it back from the lab. I'd rather cut it off than have to go into the office. Just a personal, but this is a great, very, very strong, no eugenol involved, so you can bond. All right. So let's look at final placement. Crowns, bridges, inlays, and onlays, final placement. So Marshall Fagan came out with a report. He says, every time the clinician places a final restoration, there are 3 key considerations to start with: the type of restoration, the material being used, and the tooth preparation. Zirconia. Over 80% of the single restorations fabricated in the dental lab today. What are 2 common problems with zirconium? We're getting better on aesthetics. In fact, we're pretty good. And cementation and bond. When zirconium first came out, it was a hassle because we were treating it as if it was like Emax, lithium disilicate. And we were using phosphorus. The worst thing you can do is skip phosphoric acid around, either placing it on the tooth or anywhere around zirconium. It will not bond. And is also today the most re-cemented bonded restoration. Why? It's all about the technique. So let's take a look at the technique that I use. I use VESALIS SimCore. Now, I just shared with you VESALIS Core, but this is VESALIS SimCore. And I will tell you, it has the tooth primer. It has the restorative primer. I have one product in my operatory. I use this product here for both core material, as you can see here, and also for cementation. It is incredible material. Absolutely incredible. It's my go-to and my posterior adhesive. And I have to share with you, I just bonded in on my buddy who's a dentist, his anterior restorations, and it was fantastic. You got to be careful with the shade if you're using Emax. All right. So a dual cure composite for adhesive cementation, post and cores buildup. It has the tooth primer, which has the MDP. Now, for years, Pulsar had the patent on the MDP. It was released some years back. And that's what's important when you go to use adhesives on zirconia. It must have the MDP in it. That is the key. And then there's the restorative primer. You treat the restoration after you try it in with the restorative primer, which also has the MDP in it. And they do make a try-in paste, like if you want to use it in the anterior. It's a fantastic cement. So let's take a look at how this works. Here's our product. We got the tooth primer, the restorative primer, and the SimCore. So we tried it on, and this is lithium disilicate. I want you to watch this procedure very carefully, please. We tried it on, rinse it off. Any contaminants with water, just dry it, okay? So here my assistant is dispensing the restorative primer. She is placing it on with a micro brush. For 1 minute, we let it set and air dry it. Then what I do is I take a micro brush with the tooth primer. For 20 seconds, I scrub the tooth. 20 seconds. Fill it. Now this is Emax lithium. Seat it. Take a micro brush, make sure I can see that it's all the way down on the margins. And then I will light cure that for 2 to 3 seconds. No more. This stuff gets hard. For me, it's been the best cement, posterior adhesive cement I've ever had in my hands. I'll remove the part that I tacked, and I'll go back in and I'll light cure the interproximals because it doesn't go. And then what I do is just 2 or 3 seconds, again, to cure that interproximal. I'll floss the area. We call this the easy peel. We've named it the easy peel. After I floss the interproximals to make sure I get in between my floss, I'll do a complete cure. In this material, this is Emax dilithium silicate. Lithium disilicate, excuse me. And if you look here, this is exactly that tooth, the root canal. And I want you to observe something here. There's the core. There's the Vasalis SimCore. I want you to look at the film thickness and the radiopacity on this restoration. There's the radiopacity, 13.5 microns film thickness. Nothing. That is a beautiful adaptation. And it is strong. It is very strong. Now let's take and use the same adhesive cement in a zirconium bridge or crown. There's a couple of steps that are just a little bit different, okay? Again, to remind you, 80% of the single restorations, 2 common problems, aesthetics, cementation, and most re-cemented. I will tell you that the aesthetic problem is almost completely gone. It's amazing what our lab technicians can do with zirconium, especially in the anterior. So here's the bridge. You can see without even guessing that it's zirconium. If you look at the underside, first thing you're going to do after the try-in is you're going to micro etch it with a less than or equal to 50 micron oxide powder. You're going to micro, take it to your lab, unless you have one chair site. And then what you're going to do is you're going to treat it with an Ivoclean or zirconium cleaner. You can use zircon. You clean it, you place it in there, rinse it out, and dry it. So it gets rid of any sand particles. But this is for adhesive. You're going to roughen that zirconium. No phosphoric acid. Don't even think about putting phosphoric acid around zirconium. Then I'm going to put my restorative primer for 1 minute. Have you ever taken off a temporary and you see this dark? Don't panic. I've actually had patients where I've done smile makeovers or full mouth reconstructions, and they call me and say, I think my tooth's dying. It's black underneath my temporaries. It's micro leakage. Usually Conceptus takes care of that, but once in a while you still get that. All you do is take your everyday hydrogen peroxide and it comes right off. So before you start your adhesive technique, you just take a micro brush, clean it off. Real easy. Then after that, you're going to rinse, dry it, and you're going to use your tooth primer, your Versalis tooth primer, for 20 seconds. Remember, it's self-etch. It has the NDP in it, and you're going to scrub each one of those teeth for 20 seconds. What I do is I scrub one, let it set, scrub the other. I let it set for about 20, 25 seconds. Then I'm going to air dry it. My assistant will load the cement. Here's the great news. You got plenty of time. Okay, you can't light cure this. Remember, it's zirconium. So you have plenty of time. Don't even panic. Lots of working time. Initial set times 4 minutes. And this is what it looks like. Now, after you place this, okay, and I've cleaned up here in the patient, I don't want you to light cure. Many times manufacturers will tell you to light cure the excess and remove it while the rest of it is curing, the chemical cure inside. I say don't do that, because what happens when you light cure it, I have the patient immediately bite down on the cotton pellet. I remove the excess, make sure it's seated, and I can see those margins, and I have them bite down for 4 minutes. The reason I don't light cure it is because I light cure it, remove the excess, they bite down, it breaks that bond, because it seats further most of the time. In most cases, it's just microns, but it seats further. So what I do is take the micro brush, clean it up, and that is a beautiful restoration. Here, I'm going to show you, here's the 4 minutes in the anterior. I just set some anteriors. Here it is after 4 minutes. I want you to watch how easy this peels. That comes off so nice. For years, you struggle peeling that off. The real easy peel. Now I want to watch this video a second. Okay. Watch this. Oh, nice. Same, that's the video from that. Beautiful. That's how easy it is. Okay. So last thing is we're going to talk about is back to temporaries. For many of us, we do anterior work. And when you do anterior, you usually do a diagnostic wax up. And with its diagnostic wax up comes the original models, the diagnostic wax up. I had my lab technician do this in the gray wax just to show it shows up better on the slides. A prep guide, and also a Siltec stent that is made from the diagnostic wax up and then injected with impression material to make temporaries. So here's different types of diagnostic. You can get really fancy on these. There it is before the diagnostic wax up and after. So let's look at temporization. So I'm going to use the Versalis temp. I'm going to fill that, keep the point of that in. I'm going to seat it. And remember the soft tissue. And then what I do is when I seat it, I massage the buccal and lingual just for the initial 3 to 4 or 5 seconds. And I'm going to show you when you have, and you get lucky once in a while, but actually after you do this enough, you get lucky many times. I'm just removing this right now. Check the bite. And there it is. The redness around number 9 is actually from, because I did some laser during the preparation. And there are beautiful temps. I have not trimmed a thing off these temps. You can get real fancy, and I love doing this. My assistant, she sometimes kicks me under the chair because I like to putz around. But this is by Kerr. It's called Color Plus. You can add blue for the translucency on the temporaries. Here, we're adding a little white. We're adding a little ochre around the gum line. And then I'll use Heliobond unfilled resin to glaze it. And that's the final results. Beautiful temporaries. And they look good. And great temporaries. What is the whole purpose of a good temporary? Obviously, if you're doing a posterior temporary single temp, is to hold the space, but also, good temporaries, good margin adaptation gives you good healing gingiva after you worked on it, but also it gives you good final results. And this is what kind of work we want to place in our patients. So I think we did good. Hope everyone learned a little bit. Questions? I would not use anything but the recommended zirconium. I don't know the answer to that, to be quite honest. I would not use anything but a manufacturer produced zirconium cleaner in that, like I showed you, the Ivoclean. There's different. Visco makes one, but there's different. And Vista Apex makes one. Vista Apex is a good company. They make another one. So I don't know the answer to the sodium bleach in that. I would stay away from that just because I don't know. I don't want to mess up my bond. I don't want to mess up chemicals in that. What material is the cement? The Visalis it's an adhesive cement. It's a composite. Most adhesive cements are real fine film thickness. Do you remove entire composite? Existing restorations need to be replaced? Great question. All these are great questions. Not always, I have to be honest. Here's one for you, though, in addition to that. If there's no decay around that, because research shows if you seal decay, I mean, if you've been in dentistry long enough, chances are in your lifetime, you've probably left some minor decay, but if you seal that and it's sealed good, the bugs can't get the medicine they need to grow. It will, the research shows it will die, but I do try to remove all the decay. There's no question. But sometimes if it's a restoration that perhaps at the cable surface margin, it's where it's broke down in decay, I'll be conservative. I mean, I don't want to wake up the pulp if I don't have to. But here's one for you. What do you do when you have, and we all see them, a deep, deep amalgam, and it's down there, and it's lying right on top of that pulp horn? I have to be honest. Sometimes I'll leave them and say, explain to the patient, if you take an x-ray, you're not in our office and you go to a different office and someone says, well, they left an amalgam in there. If there's no decay in that, I'm not talking about superficial. I'm talking about, potential for a pulp exposure. I'll leave that. That's a great question. So I think I covered it up, but one of the things I'm very, very, I love to do is, this is my email and my cell number. Please do not hesitate to email me, to call me. We learn from each other. Something comes up about materials or procedure or anything, remember to bevel. Remember, I like using universal composites, the chameleon effect. Be proud of your work, place anatomy, polish them, take your time, get beautiful results. And just be proud of it. You said keep phosphoric acid. I said phosphoric acid. Do not etch the prep if you're using a self-adhesive. You can, but don't use phosphoric acid. I would not, don't do it. Don't get phosphoric acid near. Even, see, what happens is saliva has phospholipids in it. So if you have some, like around second molars in the lower or even first molars, and you're getting ready to cement and some saliva gets in there, there's phospholipids in saliva that can cause debonding. It will not allow the bond to take place. So keep phosphoric acid a mile away. Is sandblasting kind of as causing microfractures? Not on the zirconium surface. We're not going to sandblast any type of porcelain, pure porcelain. Thank you for the comment. Do you ever have the Visalis temporary stick to the core? Great question. Okay. So here's what I do sometimes. If I'm doing a prep and it could use a small core, I'm not talking about an endo core. I'm talking about a small core. You remove decay, tooth vital, maybe, and you have a defect and you could use, a medium to small core. I will have my lab block that out. I don't do the core then. But what I do is I have them block it out, because here's the situation. One, if you've been in dentistry long enough, you know temporaries can pull off cores. But also, the other thing is that I rather have a bond to the tooth from my restoration and not a core, if that makes sense, even though it's same material. So what I'll do is have them block it out, and I'll use my sim core, because it's a cement, that's what it stands for, cement and a core, so that when I cement it, it adds the core to it. And it's legit that you should charge for a core. The other thing is that let's say that you're doing interiors and you use your Visalis temp or any temp, and you did a block out. You want to block out the dark color, or you did just a core, a little bit of a core buildup. You go to take the temporaries off. Again, if you've been in dentistry long enough, you've done this, and the core comes out. What you can do is use an non-oxygen inhibitor, Vaseline. You can etch that tooth, either self-etch or total etch, put the adhesive on that. If you're self-etch, just put the tooth primer for Visalis and let it set, and then add a little bit of core material, seat that crown, because you put a little Vaseline on the inside, seat that crown and cure through it. If it's Emax, okay, pull the crown off, it'll come off, and remove the excess, and that fit will be fantastic. So anytime you have a core that comes off that you need that core there, if it's like in the anterior or whatever, just put something on the inside that it doesn't stick to, such as Vaseline, real thin, and process it that way I just mentioned. In other words, you self-etch either with the Visalis tooth primer or total etch with adhesive, add it, because it is a composite, put the crown on there, cure it, and it comes right off. You'll be golden. Okay. I have my phone number and email. Please don't hesitate.